you organize the tracing of a patient. Well, you talked about the follow-up, but have you any solution tracing a patient who is not coming back to your hospital? So, or well, for example, you have a failed surgery and a patient decides to go to another hospital. Do you have any chance with your registry to trace this patient, or is this, as in common registry, just a new case and without the finding actually that there is a complication?
At the moment, I think it's not possible to automatically follow this patient. So we rely on the fact that the patient declares the revision case in the registry. And if he clicks on that he had a revision, some other questions come up. Where did he have surgery before? And so it's a manually work for the physician that's treating this patient to look what's going on. So I think it's difficult to automatize these steps. And the other thing is that, of course, the surgeon is asked whether he's doing a revision case. And so either the patient or the doctor or both can announce that it's a revision case. And then someone has to get active. It's the latest revising physician, I guess. So it's not yet that far with a registry that we have a easy solution. And we have to figure out how we can combine the two cases and make one of it. So this is not done so far. It's a very raw version.
Yeah, it's very complex. Mm-hmm. And congratulations that you also follow up your conservative patients, which is very sensible in this eye joint. Another question would be: do you already have a database for your implants? Or how do you organize the implants you use?
Well, we don't have. Or we just have a list that's somewhere out in the internet with all the manufacturers, or a lot of manufacturers with implants, and we try to have them on the registry, but we do not have a list with all the implants that are allowed to be placed, an official list by government or whoever. So this is something that's needs to grow over the next period of time. So it's a lot of work to do. When I heard you talk, I felt very naive with this registry, because I think we are still at the very beginning. As you see, my registry is a little different. It's not made for tracing the implant itself. It's not the MDR thing. It's more, what do we do with our patients with different types of therapy? So we also have, we tried to get an algorithm for diagnosing and treating patients. So far, we didn't get this, but maybe somehow you find a kind of red line through the registry, so you can choose what are useful clinical tests, what are useful questions to ask the patient, and how do we follow the patient. And so this is a mixture of a registry to where you learn how to go through the procedure. You can put in your data and you can see what you do, a tool for learning.
Yeah, but it's just a recommendation, because, well, industry now is really interested in tracing their products and to assure the quality of their products. And this is an opportunity for you to get money to afford your registry. Yeah? This is what we do with the DWG right now. So we sell the data, and therefore we can pay for our registry, for the cost for our registry.
Yeah.
So industry would be interesting. Probably they support you.
Yeah, this is something that needs to come. I'm waiting for the last upgrade, and then a lot of bugs should be fixed, and it should be better than what we have now. And then I have to talk to the different companies. That's the aim, and invite them to play with us.
And so sure, if you would help us, Rolf, that would be great.
And
Martin, hi, John. Oh, sorry.
Hi, John.
Martin, it's John Stark. I have a question. And one thing that is very important to me is that our technique be followed exactly, interoperatively. And I didn't see a section on your form as to whether or not the technique was followed exactly. We have radiologic criteria for position and guide pins and all that kind of stuff, and a sequence of instruments that has to be used.
Mm-hmm.
And if the surgeon doesn't do that, then we can't promise promise the outcome, of course. So my question is, what if any provision is there in your follow-up method for intraoperative data?
Well, that's something I didn't think of so far. Also, we have no way to document complications that happen during or after surgery. So this is, well, maybe we need to extend it for these questions. So far, it's not implemented.
May I comment on this, on your argumentation? As I'm doing this registry thing now 15 years, in the past, the registry must be a compromise between affording the data input in the clinical settings. No, it's always too less data you are able to input, because you're not willing after an operation to sit down for an hour to put all this data in. Well, maybe you are, because you're really interested, but the main or the majority of all the surgeons and physicians won't do this. And therefore, the registry must be very compact. Just in case you are able to have interfaces, well, technical solutions between your information system, hospital information system, and the registry, then it will be able to put in just much more data. These questions you had about techniques, special techniques, and really go into it in the theme. But right now, with your registry, with manual input, no chance to be too detailed. People won't do it, I promise you.
Well, I see the same problem with a longer form later. And so we're kind of wondering if something as simple as a card attached to the implant, which with a series of simple questions, was the technique followed? Did it meet the radiologic landmarks? Were there any problems? And that would seem to be very helpful in answering that question. I just didn't know if you'd considered that.
Well, not in a automatic way, but I think if the thing with the card would work for you, maybe we can have a little spot on the registry where you can load up documents, photographs, scans, PDFs for a certain patient, so you can document what you have done. So maybe the surgeon has, if he wants to, the possibility to load up pictures or documents, and then it's in the registry. But well, the registry, I think it's not the, or the ESAR is not that registry that we heard is searched for by the politicians. It's a different registry. It's more for the outcome and the way the patient is improving. It's not for the just for revision cases.
Can I have a comment?
Yeah.
Yeah. Well, thank you, Martin. Very nice lecture. But what I see, it's like a really protocol for medical. It's a study protocol. It's very, very complex, and of course it is very important. But I agree with Professor Sopotka. It will be maybe too much information for the normal doctor to fill in. In Sweden, we have a spine register, and the sacroiliac fusions are integrated in the spine register since 2017, and it took a while to make it coming into the Swedish spine register, but I think it works well. But your protocol is more complicated. it will. I am afraid it will take too much time. But I think we have a lot of time to discuss this further on, because it's necessary to have protocols. It's necessary to have registers. So I'm happy to hear that. Thank you.
Well, I think it's the ways that we get some doctors who work with it, and then we see what is necessary, what is missing, and what is too much. And then it's always easy to take out some questions and to reduce the questions and see how it works.
Yeah.
So this is just a raw structure, and then we have to go on and now real work starts, I think, when it's on the market.
Yeah. Yeah. Thanks.
I think we should move on.